Welcome to the COMLEX 5-minute review. Please visit COMLEXFlashcards.com for complete COMLEX prep resources. On COMLEXFlashcards.com we have additional lectures including the full version of this lecture posted on our blog. Again, you can subscribe to the podcast, listen to lectures, and get rapid review facts as well as flashcards and more information about the COMLEX board exam. Today's topic is diabetes, and the definition is mainly a fasting glucose greater than 126 or a random glucose greater than 200 on two separate occasions. Okay, patients generally with diabetes have some sort of an insulin resistance where they have decreased glucose uptake or lipolysis going on, or there is excessive hepatic glucose output. And other patients may also have decreased insulin secretion. So this insulin resistance can, in normal beta cells, could be causing hyperinsulinemia, okay? And in abnormal beta cells can lead to hyperglycemia with a relative insulin deficiency. So there's two ways you can develop insulin resistance and its effect. Now it's caused by several factors. One could be genetic, with mutations, glucose transportation mutations, signaling proteins causing problems. And the other one is acquired, like obesity, stress, medications, inactivity. All these things are leading to more and more insulin resistance. Let's go straight to the point of what the COMLEX is going to ask you about. For type 2 diabetes, first of all, you have to understand how to make the diagnosis. This is an insidious form of diabetes. Patients can present with mainly several criteria. Okay, when you see the first patients, they have signs of possible polyuria, polydipsia, polyphagia, although that's more common in type 1. Patients commonly present to you and you measure a fasting plasma glucose and it's greater than 126 on two separate occasions, or random glucose is greater than 200, plus they have symptoms. The random 2-hour postprandial glucose greater than 200 is also considered to be a test that's of high concern. So when patients come in, you want to look at those initial glucose lab tests. They are very important. And also patients also have symptoms such as non-ketotic hyperglycemia, and this is seen in patients with poor glycemic control. We'll talk about this later. Also, patients have obesity, truncal obesity especially, and a genetic predisposition. So those are just some of the key things you want to keep in mind as you're examining the patient. You also want to take a look at unexplained weight loss recently. Again, we mentioned the polyuria, polydipsia, polyphagia. So in terms of the definition, a blood glucose higher than normal is considered to be diabetes, and by that we mean that the levels in a person should be approximately 80 to 120 for the blood glucose monitoring, and postprandial levels should be obviously much lower, to less than 180. So when approaching patients, you have to understand the pathophysiology of both the types of the diabetes. In type 2 you have an insulin resistance plus some sort of a relative insulin deficiency, and so what happens is that you basically lead to increased glucose, leading to increased secretion of glucose, consequently causing pancreatic failure and overt diabetes present in most patients. There's no HLA associations. Type 1 has HLA associations. Type 1 is also islet cell destruction. There's some absolute insulin deficiency in type 1, and ketosis does develop in the absence of insulin, prevalence 0.4% of patients. Okay, so type 1 has ketosis, it has HLA associations. Type 2 generally has truncal obesity, it's associated with non-ketotic hyperglycemia, more insidious in onset. Now type 1 patients are usually younger, adults to children, and type 2 are mainly adults greater than 45 years of age, although that's changing too. So to make the diagnosis, you would really focus on the fasting glucose or the random glucose tests, and look at the hemoglobin A1C, although that's not a measure for exact diagnosis. So if the COMLEX asks you about the diagnosis, you're going to go with the fasting glucose or the random glucose test. Okay. Now, let's talk about some of the criteria for managing diabetes. You want to have self-monitoring of serum glucose, okay, 3 to 4 times a day, recommended for type 1 and less frequently for type 2. You want to have continuous glucose monitoring. That's really important. And if the question COMLEX asks you how many times a day should a person be measuring, well, it should be multiple times a day. Okay, the glucose levels for the hemoglobin A1C should be less than 7 according to the American Diabetes Association, and preprandial levels should be between 70 to 130, whereas peak postprandial levels should be less than 180. Okay, so these are some of the values you need to keep in mind as you're proceeding. Let's take a look at some of the medication goals. You want to control their glucose. Hypertension, this could be a test question. It should be less than 130/80. Again, you want to prevent diabetic nephropathy from developing, and one of the key things is to keep the patient on an ACE and an ARB. This is protective to their kidneys, and it's highly important to do so. Patients also should be on statins with an LDL goal that should be less than 100, and if they have more risk factors, it should be less than 70. Now, the patients are expected to have an albumin level of less than 30, but if they have a level that's between 30 to 299, and that's considered a cause of microalbuminuria. Now, in microalbuminuria, you are concerned about protein leading to nephrotic syndrome and finally renal failure. There is diffuse glomerular basement membrane thickening with a nodular pattern called Kimmelstein-Wilson nodules. It's usually accompanied by retinopathy, and so if you have a lack of retinopathy, it usually suggests that it's some other source causing this. But once again, tight blood pressure control, ACE inhibitors, ARBs, low protein diet is key, and if this doesn't work, then possible dialysis. Again, macroalbuminuria is greater than 300. So before we end this lecture, let's review some of the medications. Okay, patients should be on tight lipid controls. Patients should have their LDL less than 100, and if they have coronary artery disease, then the value should be less than 70. Triglycerides less than 150, HDL greater than 40 for men and greater than 50 for women. And what you want to do here is get a microalbuminuria yearly with spot microalbumin/creatinine ratio. Okay. Get the patient's hemoglobin A1C every 3 to 6 months with a goal less than 7, and control their glucose well in order to prevent any complications. Also, the blood pressure less than 130/80, LDL less than 100, triglycerides less than 150, HDL less than 40, and putting patients on statins, especially in all diabetics, even without coronary artery disease, has shown to be beneficial. And aspirin if the patient is greater than 40 years of age. Okay, and you want to do a dilated retinal exam yearly, and at the minimum have the patient see a podiatrist yearly. Keep in mind that patients can also have accelerated atherosclerosis, infections like candidiasis, mucormycosis, necrotizing, and external otitis, and also certain dermatological conditions like acanthosis nigricans, necrobiosis, lipoidica, and so patients typically have several things going on. Now, in addition to that, patients have retinopathy. This is usually non-proliferative, dot and blot and retinal hemorrhages with cotton wool / protein exudates are seen. Some patients have proliferative retinopathy, in which you have neovascularization, vitreous hemorrhages, retinal detachment, blindness, and the treatment for both of these is photocoagulation. Again, we mentioned the antiplatelet therapy, and this should be beneficial to patients, especially putting the patient on aspirin and statin if they have a history of any coronary artery disease. Well, this completes our lecture. To get the full lecture, please visit www.comlexflashcards.com, where we will talk in detail about the management of diabetes, various medications, and how you should approach patients in various scenarios for both type 1 and type 2 diabetes. Again, visit www.comlexflashcards.com for the complete lecture. Good luck in your preparation.